Welcome to section 9 of neuropathology. In this section, we'll be discussing neurocutaneous disorders. Let's get started. This is our overview slide. Let's begin by discussing some basic principles. Neurocutaneous disorders are inherited diseases that affect various organs, primarily the central nervous system and skin. These disorders most commonly follow an autosomal dominant inheritance pattern, with Sturge-Weber syndrome being the only exception. Another common theme is that they all involve mutations in tumor suppressor genes, but again, Sturge-Weber syndrome is an exception. All right, the first disorder we'll be discussing is Sturge-Weber syndrome. This is a congenital, non-hereditary anomaly of neural crest derivatives. It arises as a result of a somatic mosaicism mutation in the GNAQ gene. Somatic mosaicism means that two or more populations of cells with different genotypes are present throughout the body. In this case, there are cell populations that have different GNAQ gene mutations, resulting in Sturge-Weber syndrome. The mutation occurs after fertilization, resulting in different cell populations in multiple organs. For more information on somatic mosaicism, be sure to check out our genetics section within Biochem. The final point is that this disorder is characterized by capillary venous malformations in the eye and brain. All right, now let's talk about the presentation. The most notable feature of Sturge-Weber syndrome is a port wine stain capillary malformation of the face. This characteristically presents in a V1 to V2 distribution of the trigeminal nerve. Another feature is a leptomeningeal angioma on the same side to the port wine stain. A leptomeningeal angioma is a venous angioma of the leptomeninges, which are the two innermost meningeal layers, the arachnoid and pia mater. This often leads to intellectual disability, seizures, and epilepsy. The last major feature of this disorder are episcleral hemangiomas, causing increased intraocular pressure, leading to early onset glaucoma. Episcleral hemangiomas are simply hemangiomas overlying the sclera, or the white part of the eye. Here we see an image of an infant with Sturge-Weber syndrome. It's easy to appreciate the port wine stain on the infant's right face in a V1 to V2 distribution of the trigeminal nerve, right here. The next disorder we'll discuss is von Hippel-Lindau syndrome. This is an autosomal dominant syndrome caused by a deletion of the VHL gene on chromosome 3. VHL ubiquinates hypoxia-inducible factor 1A. Deletion of this gene leads to the formation of numerous tumors, both benign and malignant. It presents with hemangioblastomas, which are vascular tumors of the CNS most commonly seen in the retina, cerebellum, and spinal cord. This disorder is also associated with bilateral renal cell carcinoma, pheochromocytoma, and cysts in various organs, such as the kidneys, pancreas, and liver. This image represents the typical distribution sites of hemangioblastomas in von Hippel-Lindau syndrome patients. Image A is an illustration of the CNS, including the brain, brainstem, cerebellum, and spinal cord. B through D are contrast-enhanced MRI images demonstrating representative locations of hemangioblastomas, represented by the hyperintense lesions marked with the white arrows. B is an axial view through the cerebellum, C is a sagittal view through the brainstem, and D is a sagittal view through the thoracic and lumbar spinal cord. All right, before we move on, let's try a question. A 23-year-old female presents to the emergency department complaining of headaches, blurred vision, sweating, and a racing heart. Upon admission, her blood pressure is 165 over 98 millimeters of mercury, and her heart rate is 109 beats per minute. She has no significant past medical history, but her father was seen for similar symptoms around her age and was eventually diagnosed with renal cell carcinoma. A 24-hour urine test shows increased levels of metanephrines, a mutation in which chromosome would be expected in this patient. All right, this patient has symptoms indicative of sympathetic hyperactivity, headache, blurred vision, sweating, palpitations, hypertension, and tachycardia. Furthermore, she has increased levels of metanephrines in her urine, indicating a possible pheochromocytoma. Her father's past medical history of similar symptoms and diagnosis of renal cell carcinoma provides evidence that this disorder is inherited. An inherited disorder consisting of pheochromocytomas and renal cell carcinoma is indicative of von Hippel-Lindau syndrome, and this syndrome occurs due to a mutation in the VHL gene on chromosome 3. So the answer here is chromosome 3. All right, the next disorder we'll discuss is tuberous sclerosis. This is an autosomal dominant syndrome secondary to mutation in either TSC1 or TSC2. TSC1 is located on chromosome 9 and encodes for the protein hamartin. TSC2 is located on chromosome 16 and encodes for the protein tuberin. Mutation in either of these genes results in characteristic formation of hamartomas, as well as other benign tumors and specific cutaneous manifestations. A hamartoma is a benign tumor consisting of tissues and cells normally found in the area of the body in which it grows. Tuberous sclerosis characteristically presents with benign cortical hamartomas, commonly referred to as tubers, which often cause intellectual disability and seizures. Other benign tumors include cardiac rhabdomyoma and renal angiomyolipoma. There are various cutaneous manifestations that help distinguish tuberous sclerosis from other neurocutaneous disorders, and these include adenoma sebaceum, which are small nodules in a butterfly appearance around the nose and cheeks, ash leaf spots, which are hypopigmented white macules on the trunk and extremities, shagreen patches, which are flesh-colored leathery papules in the lumbosacral region, and finally periungual fibromas, which are small benign tumors that grow under or around the nails of the fingers and toes. If we look at the image on the left, we can clearly delineate adenoma sebaceum, which again are small nodules in a butterfly appearance around the nose and cheeks. And if we look at the image on the right, we can see a great example of an ash leaf spot right here. As you can see, this is a hypopigmented white macule on the trunk. All right, let's finish up by discussing both types of neurofibromatosis. Let's begin with neurofibromatosis type 1. Neurofibromatosis type 1, also called von Recklinghausen disease, is the most common type of neurofibromatosis. It's an autosomal dominant syndrome secondary to a mutation of the NF1 gene on chromosome 17, which encodes for neurofibromin. Neurofibromatosis type 1 has a variable presentation, but has characteristic findings such as neurofibromas and cutaneous manifestations. Neurofibromatosis type 1 characteristically presents with neurofibromas, which are nodules on or under the skin, and these may cause intellectual disability and seizures when found in the CNS. The eyes may also be involved, and we may see Lisch nodules and optic gliomas. Lisch nodules are pigmented hamartomas of the iris, and optic gliomas are tumors that arise in or around the optic nerve. Neurofibromatosis type 1 is also associated with pheochromocytomas, as well as cutaneous manifestations, including café au lait spots and axillary and inguinal freckling. Café au lait spots are hyperpigmented brown macules. We can clearly see the skin riddled with neurofibromas, which are, as you can see, nodules on or under the skin. And if we look at the image on the right, we can see a great example of a café au lait spot. Notice that this is a hyperpigmented brown macule on the abdomen. This is a textbook example of a patient with Lisch nodules. As you can see, these are pigmented hamartomas of the iris, and we can see many of these brown spots scattered throughout the blue iris of the patient. All right, let's try another practice question. A 24-year-old Caucasian man presents for a routine visit to his primary care physician. He does not have any current complaints. Vital signs are within normal limits. On physical exam, he has numerous firm, rubbery nodules of varying sizes on his back. He also has small pigmented spots on his irises and a hyperpigmented macular lesion on his left lateral thigh. What other cutaneous findings could be present as a result of this patient's condition? All right, this patient clearly has neurofibromas, as suggested by the numerous firm, rubbery nodules of varying sizes on his back. He also has Lisch nodules, the small pigmented spots on his irises, as well as a café au lait spot, which is the hyperpigmented macular lesion on his left lateral thigh. These are all findings indicative of neurofibromatosis type 1. The other common skin finding that could be found in this patient is axillary and inguinal freckling. All right, the last disorder we'll discuss is neurofibromatosis type 2. This is an autosomal dominant disorder secondary to a mutation of the NF2 gene on chromosome 22, which encodes for Merlin. It characteristically affects both eyes and ears. And a good way to think of the manifestations of this disease is the common saying that NF2 on chromosome 22 affects 2 eyes and 2 ears. It presents with bilateral vestibular schwannomas, also referred to as acoustic neuromas, and this leads to tinnitus, hearing loss, and vertigo. A vestibular schwannoma is a benign tumor of Schwann cells that grows on the vestibulocochlear nerve, or cranial nerve 8. Juvenile cataracts are also often seen with this disease, and other findings include meningiomas and ependymomas. This is an MRI image demonstrating the location of a vestibular schwannoma. All right, now that we've covered the information, let's review with a final question. A 5-month-old infant is brought to the emergency department after suffering a seizure at daycare. His daycare provider said she was holding him in her lap when he had a strong bilateral symmetric jerk of his torso, extremities, and head. This occurred about 8 times in quick succession. He is afebrile and all vitals are within normal limits. Developmentally, he does not roll or grasp at objects, but he does orient towards sound. He has multiple pink papules on his nasolabial folds and cheeks and a coarse plaque on the lumbosacral region. Renal ultrasound is most likely to reveal which of the following: A. Angiomyolipoma, B. Renal cell carcinoma, C. Wilms tumor, or D. Multiple cysts. All right, this patient is presenting with afebrile convulsive seizures, developmental delay, and cutaneous findings. Multiple pink papules on his nasolabial folds and cheeks is indicative of adenoma sebaceum. A coarse plaque in the lumbosacral region is describing a Shea-Green patch. Therefore, the patient likely has tuberous sclerosis, which commonly presents with renal angiomyolipomas. So the correct answer is A. Recall from this slide that patients with tuberous sclerosis can present with many symptoms, including intellectual disability, seizures, renal angiomyolipomas, adenoma sebaceum, and Shea-Green patches. B is incorrect because while renal cell carcinoma can occur in patients with tuberous sclerosis, it is a very small percentage, and angiomyolipomas are much more common. C is incorrect because Wilms tumor is a kidney tumor that primarily affects children but is not associated with tuberous sclerosis. D is incorrect because the presence of multiple cysts is associated with polycystic kidney disease. So again, the correct answer is A, angiomyolipoma. And that concludes this section.